Mashallah, we are now on the last stretch of our Islamic Medical Conference. And for our last topic, and definitely not the least, is the second part about the plenary on end-of-life medical care plenary sessions. So please allow me also to remind everyone to please start to share your questions in a little while, especially on the DNR topic earlier and also for this coming talk. We will try to share it later to our esteemed speakers during the open forum. So in the name of Allah, the most gracious, the most merciful, praise be to Allah and prayers and peace be upon the messenger of Allah. Accordingly, end-of-life care presents many challenges for clinicians, as well as for patients and their families. Moreover, the care of the dying patient must be considered within the context of the psychological, physical, and social experiences of a person's life. The challenges faced by the dying patient are substantial and potentially overwhelming. These challenges include physical pain, depression, a variety of intense emotions, the loss of dignity, hopelessness, and the seemingly mundane tasks that need to be addressed at the end of life. Clinicians who oversee the treatment of patients at the end of life often face also obstacles to providing optimal care. So among these obstacles are inadequate preparation for facilitating difficult conversations and personal discomfort with dying and death. As I have noticed, none in this medical article tackled the aspect of spiritual and any religious interventions as part of the context in the care of the dying patient. As Muslim practitioners, it is vital for us to integrate our Islamic perspective on this matter for us to improve our holistic care of our patients, especially those who are terminally ill most of the time. So, to enlighten us on the Islamic perspective on end of life care and clinical death, I have the honor and privilege to introduce our esteemed speaker. He is an assistant professor in the Department of Sharia, doctorate in Islamic jurisprudence at Al Qura University. Also a researcher in contemporary issues on medicine. Ladies and gentlemen, let's help me welcome to the virtual stage to talk on the Islamic perspective on end of life care and clinical death. We have uh, Dr. Tariq bin Talal bin Mohsin Anjawi. Doctor, Assalamu alaikum.
وعليكم السلام ورحمة الله وبركاته. Hi, brother, and hi, everyone. It's an honor to be here. And I will share the PowerPoint so we can start and get the most of our time, inshallah. I just need you to tell me if the slides are clear on the screen, I think.
Yes, it's clear, Doctor.
Okay. So let's go, inshallah. Assalamu alaikum wa rahmatullah. Bismillah, alhamdulillah, sallallahu ala rasulillah. Peace be on his prophets. This is a lecture about the Islamic perspectives on end-of-life care and clinical death. Most of the lecture will be on the first topic, Islamic perspectives on end-of-life care, and we will see if we can spare some time for the issue of clinical death. I just want to put forward a note that I've been studying this issue for a very long time. My PhD was on the rulings of decisions on life-supporting treatments. I will use the abbreviation LST, which will stand for the life-supporting treatment, or you can call it life-sustaining treatments. It handles the same kind of treatments which support patients when they are critically ill to save their life, compensating critical organs like ventilator or kidney dialysis and other treatments that I think most of you are familiar with. So let's give an outline about the main topics we are focusing on today. I will talk about the end-of-life decisions the development of a dilemma, where I will give a very brief introduction about the historical changes that leaded us to what we are on today. I will also talk briefly about the mainstream fatwa approaches, because we have multi-fatwa approaches, maybe I can say. So it's important to have a very brief idea. So when I enter to my deep way of tackling the issue, it will be clear where I am focusing. Also, I will highlight the pillars of the correct methodology I think it should be used to study such issues. As you all know, methodology is a very important starting point in studying issues or trying to reach solutions for problems, especially for complicated problems. And no doubts we are talking about one of the most complicated problems. Also, I will highlight the related Islamic principles, because when we go to the details, we will be actually trying to activate these principles, trying to make our judgments based on these principles. Also, I will try to give an idea about what permissible exits we might have for limiting care, because some of the main principles involved here might give an impression that we don't have any exit to limit care, to withhold care. This is not precise, and I will show why, inshallah. Also, I will try step by step to reach an appropriate criteria. It will not be 100% precise, because the criteria must bridge between the principles, or even between the fatwas and the rulings, and between the actual facts, or the, let me say, the day by day. Sometimes I lose the vocabulary because I don't practice English a lot. So when you are in the hospital and you start implementing things, you might feel yourself not sure what to do exactly. A criteria helps to bridge this gap. Also, in the end, inshallah, I will talk, as I said, if time will be saved, for some talk about the defining of the death, inshallah. So let's start with the end-of-life decisions and how this dilemma developed. As you know, when life support techniques, or let me say the technology developed, we had the ventilators and many other very high-tech, also some medicines like inotropes and others. And we had we started to see some problems, because these kind of interventions will sustain life, but sometimes it will not cure. And here comes the problem. If somebody's life can be sustained, and at the same time he can be cured and depend on himself, improve his quality of life, and leave the hospital, so that's perfect. But actually, that's not what happens in all times. Sometimes we can sustain life, and the patient will still be dependent on hospital interventions. So here rises the question: is the goal of care to just sustain life, or is it to cure? And if we cannot cure, should we stop sustaining life and, as quote unquote, allow the patient to die? As some might express, we will see. But mainly, this was the starting of the debate here. There were, and this is not mentioned by many of the speakers, and I like to emphasize it, there were early criminalization of the withdrawing of ventilation and nutrition, because it's a matter of cause and effect. When you withdraw ventilation, that will mostly, if the patient was in a bad state, So this will mostly lead to death. If you stop nutrition and he cannot depend on himself for feeding, then of course he will die. So this was seen as an act of killing actually, and it was criminalized. Then in the courts and in the media and everywhere, the debate arose, and there was an inclination gradually to stop criminalizing this, or at least stop criminalizing it in certain instances until we reach to what we are today, where this is just seen as a personal choice, or maybe even seen as a mercy to the patient, stopping suffering, and many other expressions that you hear to imply that this is a non-criminalized act. Also, we saw a rise of ethical debates where people consciously or non-consciously brought life versus quality of life. Some people, they think that life has an intrinsic value, and so it should be saved, and we should struggle to save it until the last breath of life. Where other people say the goal is quality of life, and life has no intrinsic value. So if there is no quality of life, if there is a low quality of life, then what's the point? And we should not struggle for this. So as I said, some people will bring this to the surface, and some people will keep it inside of them and start to bring up different arguments. But the reality is this thing is in the background. There is a belief about life. Does it take its value from its God creation, or it has an intrinsic value in itself, or is it just what people feel that they are living good life with enough quality or not? And then the courts shifted in favor of allowing withdrawing ventilation, and it was recognized as a right of the patient, especially in patient choice-centered countries like the North America. Also, we had some natural death acts which dominated finally, and the patient gained the right to refuse treatments. And this was expanded in the 80s. So it did expand to give the choice for the patient to refuse any treatment, even if it was like a ventilator or nutrition or any other things. And also, as you may know, it's not only the patient. Sometimes the family of the patient can take the role of the patient if he is not conscious, and they will think that this was his decision if he was conscious, or any other ways that are detailed elsewhere. I'm just giving a general picture here. Most ICU deaths nowadays follow a form of limiting life-supporting treatments. So as you see from the beginning, it was just a small debate, and there were rules after that, and then it turned to a fact now that this is affecting human life. So it's a very big topic. It's a very sensitive topic. I want to ask a question here, or draw a question to your attention. Were we involved in this as Muslims? Did we have these debates? Did they detailed the debates with enough understanding of the backgrounds and the arguments? I personally think no. At that stage, at that early stage, no. Some of the outcome of the debates were introduced by some medical doctors, and they were conveyed to some religious scholars in a way that does not show the full background of this. So I think the fatwas, the research that was done was, excuse me to say, a little bit superficial. It didn't go deep to the medical facts nor the philosophical backgrounds of this issue. Okay, so let's go to a brief look at the problems of the fatwas, because I mentioned this, and I think it will give a background that I need when I go to the perspective that I think is the correct perspective. There was a problem with the BD, brain death. It was dominant everywhere. If you start to search in the internet for a fatwa about DNR, you will end up finding a lot of fatwas about brain death. But if we look to the facts and what's happening in the ICUs, DNR is not implemented only in brain dead patients. Actually, it's with any patient who is in a terminal case, and he is suffering, and he have anticipated low quality of life. This question of DNR is raised up. So we should not focus only in brain death when we discuss this issue. Also, there is a fallacy, and it's widespread amongst many of the religious Muslim scholars. This fallacy is thinking that a medical doctor, when he says something about DNR or about brain death, he is giving an expert opinion. And actually, this is not precise. Why? Because an expert opinion in this case will be a mere medical opinion. But what we have here is an opinion that is based on, yes, on some medical facts, but in the same time it contains some philosophical point views that are mainly that mainly came from the Western literature of bioethicians. Bioethics in the West is a secular bioethics. It's based on the long history of the struggle in the West to achieve personal supremacy and other philosophical principles that I don't want to go in deep details on it. So when we take this result, we should not call it medical. We should call it medico philosophical, for example. So yeah. So we should look into the details also. There is a famous fatwa that is the DNR in KSA is mainly centered on this fatwa. This fatwa is widespread, and in short, I will translate the main idea. It says that if the doctors, 3 doctors, thought that resuscitation for heart and for the lungs is not, we can translate it in English, or we can go back to the original term in English, what they call futile. If it was futile, or maybe if we literally try to translate it, we would say it's useless, or it will give no good results. So it's not appropriate also, the other term. So if 3 doctors think resuscitation of heart and lungs is not appropriate, so they don't have to use machines for resuscitation. This is 1, and 2, they don't have to go back to the patient relatives because they are not experts in this. So this is what I think. It goes back to the idea, which is widely spreaded in Islamic literature, Islamic jurisprudence literature, that when you have an expert opinion, you should follow this opinion. But the problem here is the expert opinion is not an expert opinion. It's not a medical mere opinion. It's actually an opinion that is affected by the philosophical backgrounds. So when you say it's not appropriate, what do you mean? Do you mean that it will not save life? No, that's that's not what is meant all the times. Not necessarily, at least. Many times the life can be saved, but they think it's not appropriate because the quality of life is low. Okay, so we should keep this in mind. And why I think this important, why I am bringing it in this lecture, because many people will oppose some detailed views, because they see that this fatwa gives a green light for the doctors, and I think this green light is not based on facts. It's not based on a profound view of the issue. Finally, the BD medical reductionism. Even when we talk about BD, brain death, and we start to ask doctors about their views of brain death, they give a very superficial view of the issue. They also neglect the philosophical backgrounds, and they pretend that this issue is a mere medical issue, and it's not. Anyone that sees the medical literature, he knows that this issue, it's impossible to say that it's only a medical issue. It has a very profound philosophy on it. So again, there is a reductionism in conveying the ideas and the details to the muftis or to the religious scholars. That's why in my study I got very deep in reading the medical literature, and I challenged many of the mainstream views that is spreaded in this literature, and even in the medical. For example, if we have like this Zoom meeting or any other kind of meetings, and someone talks about brain death, mostly you will hear of this reductionism. Okay, let me go to the next slide. Yes, artificial life. This is a very important point. Actually, one of the problems in the fatwas that many of the religious scholars, they think that when a patient is on a ventilator, then he's having an artificial life. It's not a true life, and they have an idea. I don't know how it came, but they have an idea that if you switch off the ventilator, then the patient will immediately be switched off, and there is no any signs of life that will stay. And this is not true, because we have some remaining signs of life. The body has its own system that can run for some time. Yes, it might be at a very bad situation, but we cannot just think of it like a machine that will turn off if we switch the button. This wrong conceptualization or wrong realization of the issue will lead to false results. We will say that this is not life, and you can just switch the ventilator based on this false realization of the problem or of the state of the patients. Finally, what I want to talk about in this slide, one of the problems also, and this is not a fatwa problem only, this is also sometimes a medical problem, is when we talk about resuscitation or life supporting treatments, we tend to talk about it as one thing, while it's not one, it's several. We have the ventilators, we have the CPR, we have the kidney dialysis, we have the blood products, we have many things. And these things differ on their nature. They differ on the results they give. They differ on the burden and on the harm that they cause sometimes. Their percentage of success of making the patient survive is also different. So to give one judgment about all of these, I think it's not precise at all. So what's the sound methodology with all with all this criticism? What is then the sound methodology that we should follow? We should at the first point, we should have profound foundations, solid foundations, profound realization of the related medical facts, and I think I give a glance at this already. Building comprehensively on certain Sharia foundations. There are many foundations in Sharia that are certain, they are not shakeable. We should build on this in a comprehensive way. When we think that we could stop life support Many foundations or many principles here can come to our mind. Saving life as an obligation, easing hardship is also an obligation, and they can interact with each other, and the results, the judgment will be affected by this interaction. When we look at saving life, and in the same time we look at easing hardship, instead of just judging that this life is useless or is not does not have a value in itself, and then we will be heading to another philosophy that's not Islamic. No, we should look at saving life and easing hardship. There is a rule which is very important. It's called the rule of no obligation by default. By default, you cannot say to anyone that you are obligated to do this and this unless you have a proof for this obligation. So this applies also to medicine. One is not obligated to treat himself or to seek treatment unless it is proved that he should do so. And when is he obligated? When does that proof comes? It's some point I will explain in the next slides. But I just want to say that these points we reach them by trying to put in our mind the two concepts together in the same time: saving life and at the same time easing hardship. If we make these two principles interact together and work together and be activated together, we would have a detailed view of when a treatment is obligatory, and so then we can say that in some instances it's not obligated and we can withhold treatments. So what I am putting forward here is not to say that we cannot withhold treatments in all times. No, I'm just saying we have to have the right basis, and we have to follow the detailed rulings that we draw from Sharia. Life has an intrinsic value. There is a lot of arguments, a lot of proofs for this in Islamic literature. For example, the Prophet ﷺ, when a man took a knife and he put it in his heart and put his weight on it to kill himself, he was suffering because he had some cuts in his hands and he was bleeding to death. So he thought that he should end his life. He thought that this remaining life does not have a value. And out of pain and suffer, he tried to mercy kill himself, if we can express it like this. So no, it was refused, and Rasulullah said that God has deprived him from paradise. So this means he committed a major sin. So mercy killing is not allowed. Life, you cannot divide life to a life that is worth living and life that is not worth living, because life is not just measured by the outcomes of matter or of money or such things. It's more comprehensive than this very narrow idea. Four, we should define when treatment is obligated based on multifactorial approach. We should think of the anticipation of treatment quantitative success. What percentage of the treatment? What is the percentage of the treatment success of saving life? Also, the treatment consequences, even the bad consequences, the side effects, the hardship. This also will go into our equation. Okay. Also, patient consent is important, and I will also elaborate on this in the next slide. So I'm just saying here that we have many foundations that we can put into effect, and this will give us a better view of the issue. This is a summary of some of the most important principles which can be used in this Sharia approach: saving life, easing hardship, no obligation by default, building on defined apparent traits. We do not say that things are obligated unless we have an apparent base. So for example, I will give an example, and please give it your attention because it's an important example. It's very relative to our contemporary issue. If we have someone that he's suffering from some medical problems, does Sharia tell him to do all what he can to save himself, even if this causes hardship, even if they were non-proved things? For example, does he have to stay at the hospital door and just put a tent at the door so he can just rush to the ER at any time when he feels any simple pain in his chest, for example? Sharia did not go to that extent. Yes, Sharia have a very big goal of saving life, but it doesn't go to that extent, because if it does so, it will cause a very big hardship. That's why if you go back to the Islamic literature, you will see many of the Islamic jurisprudence, they say that tadawi, seeking treatments, is not obligated by default. Is not obligated. Seeking treatment is not obligated. But this only applies to the kind of treatments that have a fluctuating effect. It doesn't have a stable effect of saving life. Because if some of you are interested in the history of medicine, many of the old medicine was like this. It doesn't give a statistically good results. It gives fluctuating results. Sometimes it gives success, sometimes not. So the jurist, Islamic jurist, they thought that this should not be obligated because it will cause very big hardship. Okay, what about treatments that gives a good result and it's a stable result, statistically stable? In this case, even the old Islamic jurist, they say that this is obligated. So you will find jurists that will say that you have to stop bleeding by putting some kind of robe or something to close the bleeding. You will find jurists that say that you must drink something if you have an obstacle that will obstruct the breathing, right? And you will find many jurists also talking about the obligation of eating, the obligation of drinking. So you're not allowed to stop eating and drinking and starve to death. The obligation of saving someone who is nearly drowned in the sea, for example. Because these are apparent apparent ways to save life, they were obligated. So my theory says the following: we should look at modern treatment in the same way. We should say that if the treatment has an apparent benefit for saving life, and this benefit is stable, it can be showed successful statistically, then it should be obligated by default. And if this is not the case, if it's giving a fluctuating results, sometimes it gives a success, sometimes not, or let alone if it gives a very low rate of success, then by default it's not obligated. And by discriminating between the two kinds of treatments, we can here have an exit for sometimes withholding treatments without nullifying the value of life. We don't have to do this. I think modern medicine has exaggerated on doing all what they can do. When they want to treat, then they do all things. Especially in the context of treating dying patients. So either you give a DNR and you do nothing, you raise your hands, or you do everything. Why does it have to be like this? I think it's a question good to think about. Okay, also we can build on high probability. In many instances in Sharia law, we build on high probabilities. We don't look at very low probabilities, okay? So this is also a kind of principle that we need to put in mind, because it will give us an ease, it will give us an exit to withhold treatments in some cases. Also, one of the main principles is to cause no harm and to weigh benefits against harms. It's very easy to say don't cause harm, but the most important is to weigh benefits against harms, because it's not a romantic situation in all cases. Sometimes you have clashes of benefits and harms. So in this case, Sharia gives very detailed approach to do this weighing. And I think I cannot go into detail in this, but sometimes it could apply to our specific topic we're talking about. In general, we don't force treatment. So this is also an exit. Sometimes the patient will have his choice and we can't force him. And this is in general. I might elaborate a little bit later on some very narrow exceptions for this. Also, we could consider priorities when we have simultaneous entrance of patients, and then we can just allocate resources in some cases. And I think this was a big issue brought by the coronavirus recently, and I wrote a paper about it. Now let me focus on the exits for limiting of life-supporting treatments. First, I will talk about the non-obligated treatments based on the patient need. When is treatment not obligated? We should look at the patient need. First, the patient is obligated to seek treatment only if he was in danger of dying or becoming severely harmed if left untreated. So we don't obligate, the patient is not obligated to seek treatment just to improve his quality of life or to lift hardship. This is he's encouraged to do this, and as doctors they should give this if it's if the patient seeks it. But if we want to give the patient the choice and tell him that it's not religiously obligated to seek treatment, this is the criteria. He doesn't have to do it. If he want to be patient and stay at home or something like this, then it's just the danger of dying that will make him forced to religiously forced to seek treatment. Also, and also the severe harm. In that case, if he seeks treatments, then the doctor also should provide treatment. So here we see a criteria or a part of a criteria of treatment obligation. Second, it's not obligated to treat a patient with a treatment that can't save a patient from dying. We don't have to do hopeless trials of treatments that we previously know that it will not work. But in the same time, it's obligated to provide a treatment which could save life even for a short period. So if you go to the literature and look for the CPR effects and when does it success to save life, most of the literature is centered on the idea that the patient will go out of the hospital, and some of them say 28 days survival. We're not talking about this. We're talking about survival. Any kind of survival is important because life in itself is precious and it has its intrinsic value. So it's not a question of how much he will live, but it's a question of this treatment, will it be successful or not? Also, one of the major rules for non-obligated treatments, if there is no capability of doing it, sometimes the provider cannot do it. He doesn't have the tools to do it, for example. He's not capable for a health problem, for example. So this also, of course, it will nullify the obligation of treatment. Also, we look, and this is the most important one, I think, we look at the treatment effect. And I already said this, but let me say it in maybe more precise word. A treatment is considered mandatory by default if the treatment fulfills three conditions. First, if it usually succeeds in saving life with a probability higher than 50% in likewise cases. And please take note of this phrase, likewise cases. Because in this rule, we look at the statistics, we look at the general rule, we look at the habitual facts. Because in special cases, we might have special factors, but we are talking general here. So if it usually succeeds in saving life, then we should look at it as a normal mean of saving life, like eating, like drinking, like seeking refuge from a danger, and so on. Second, it must be urgent. If there is time and the patient can wait, then he have the choice not to seek treatment at that moment. Third, it's the only mean for saving life in that case. Sometimes we have choices between treatments, so it doesn't become an obligation unless it satisfies the three conditions. And when it is like this, when it is mandatory by default, we are ought to offer this treatment and not withhold it for doubts of its success. Because in special cases, and when we come to the facts and the ER or the ICU, sometimes we have special considerations, right? So we have the default rule. By default, we are ought to provide this. Why? Because it usually works. So we go by default and we provide it, unless the probability of failure will clearly outweigh the success. So by default, we will provide, but if we have a big probability of failure, we can stop, even if there is like a 10% probability. So in case of a patient coming with cessation of heartbeat for a long time, you don't have to give a try. By default, you don't have to give a try. But if you think for a special consideration that he might have a big chance, not a minor chance, then you can give a try. But what we see in the hospitals now is if he doesn't have the DNR, then you have to do it, right? So if we can change these rules, we can bring easeship to the hospitals in another way than the DNR, because the DNR is centered on the idea of quality of life. So we need another criteria that is centered on the Islamic principles, because the current criteria, I think it's not. It might override. It might be okay in some instances, but it has major problems, I think. A treatment is non-mandatory by default. Is a treatment that doesn't show a usual success with the probability higher than 50% in likewise cases. So this is the contrary. In the first one, we said if it's usually successful to save life, then by default we have to give it. Here is the opposite. If it's usually not giving success to save life, and then we can say that it's by default, it's not obligatory. That doesn't mean that you don't try if you think it's appropriate to try. But if you think it's not appropriate for any other reasons, for example, it will give a hardship, there is no room in the ICU, and any other legitimate reasons, then you have a window here to you have an exit. A treatment is non-mandatory by default, is not considered mandatory unless the probability of success clearly outweighs its failure. So if you have like 51% or 55%, also you don't have to give it. And I think this is a personal view, because this needs studies to give a confirmation. But my personal view, I think the main thing that goes under this rule is CPR, because I think it's the most intervention that is, until now, it has a low success rates until now. And in many cases, you can tell that it has a very low success rate, even if in giving immediate survival, even if we don't go by the 28 days rule. So here is a window for CPR. Again, this is not a call to DNR patients because of this, and to leave young patients, healthy patients without trial. We can try even if it's 1%, but in some cases, if you need a window to limit life support, this might be an appropriate thing to do. This is another exit. I like to call it exits. Treatment danger. If the treatment is dangerous in itself, like for example for operations, for some operations, sometimes it gives a very big danger, equal danger to the chance of survival. So also you can withhold this. If the danger was not rare, but it was considerable, it was a big danger, also we might put this in the equation, especially if the patient is not in an imminent death situation, if he was left untreated. Here we weigh between the possibility of danger from the treatment itself and from the possibility of life-saving. And also we put in consideration the hardship that might that the patient might have. It's very hard to put it in a detailed way in this lecture or in a PowerPoint slide, but I'm just giving a glance, a general view. And if we work together, physicians and religious scholars, maybe we can detail it in some way that it can be turned to a criteria that can be easily applied in the hospitals. Finally, allocating resources. This is also a gap that we can exit from. Sometimes you don't stop because you think the treatment is not successful, but you stop because there is a priority, especially if there is a problem in allocating resources. And this has to follow specific rules. Again, it's hard to determine here. Also, we have a window in seeking ease. When a patient is facing severe hardship caused by treatment, the obligation of treatment rule is affected. How it is affected? In many ways, but I will just give one way here, which is a main way. In the treatments that we consider obligated by default, the obligation does not apply to the patient if he have a considerable hardship, unless the probability of its success outweighs its failure. In that case, we can apply the treatment and still consider it obligated. Otherwise, we will not go by default. We will not say as long as ventilators generally save life in the similar cases of my patient, then I will ventilate him. No, in this case, I have to look. Does it have a high probability or not? Why? Because the patient is facing a big hardship. So I have a room here for weighing things. But this mainly affects the obligation on the patient side, because he's the one who can say, I need an excuse because I am in a big hardship. But for the doctor, he should go to the patient choice and follow it. The rule of easing hardship is included in other rulings. As I said, it's a general rule in Sharia. We cannot give further details because of the time. Also, patient refusal is an exception. With very little exceptions, as long as the patient is refusing, we cannot enforce treatment. Now, after all this long talk, sophisticated talk, I want to say some words, and then I want to go to propose a criteria, a detailed criteria. I want to say something. You might feel that this is sophisticated and it's very hard to implement. Well, sophistication sometimes needs sophistication. If you need easy answers, give me an easy topic. But when you give me a very sophisticated topic, which raised historical debates, then don't expect a very short and clear answer. Yes, it's clear in itself, but for not a specialized person, and with the theoretical nature of the talk, you will feel that it's very sophisticated. But if we can help each others and try to implement this and modify it in some ways, we can, I think, reach to something that is better than the DNR ideas that are followed in medicine today. What's the rule of a criteria? As I think I pointed out earlier in the talk, it's the rule of the bridging. When you have a criteria, you use the medical terms and you know the situation that are running in the hospitals, then you can take these general rules and give them specific terms so that they will be tailored to the need of doctors. This is what I hope that we can do. I made my trial to do it, but I don't think it's perfect. I don't even think it's very good. Why? Because although I read a lot in medical literature and I have my connection with many doctors, but still we need the other side to give his role in this. The nature and the focus of the criteria, I just want to say that this criteria does not show all of the Sharia rulings related to life-supporting treatments. Actually, just this is a very big topics. You can talk about for example, for the monetary effect. If someone doesn't have money, what he will do. If we have a conflict of between the patient and the doctor, I wrote a book in about 1,200 pages about this. So I can never give a criteria for everything, but this is focused on the main idea of DNR, so that we can give a substitute for this. We can give a replacement for it. Also, it focuses on the I can say I focused in this on. I try to be in the safe side. I can give a criteria that will give a lot of exits, but if I do this, I will not feel comfortable. I feel more comfortable to be a little bit conservative. So if this goes to practice, it will not lead to mistakes that I will take responsibility for. So this is the beginning. It can be developed. Some of its parts actually can be modified. I'm not saying that this is the Sharia rule for 100% sure. It can be discussed, and that's why I'm proposing it to implement, to try to make a debate about it, and this might be useful actually. The first rule is about withholding. I tried to put it this way. Withholding life-supporting treatments is exclusively allowed in the following cases. First case, it's likely that the patient will be safe without the treatment being provided, so he doesn't really need it. Of course, in this case, you don't have to give it, so that he will not die or be harmed as an outcome of the withholding. So you don't have to be very obsessed about giving the treatment in all cases. You can make a trial and withhold and see what happens. You have a room for this. Case 2, the treatment life-saving effect was null or rare. You don't have to follow the 1% possibility. And I read in some medical research, it was medical ethical research. One of the researchers said that when we say that treatment is futile in terms of quantitative terms, then this means it should have a possibility less than 1%. Why? Why do we have to go to this very little percentage? Please give me just like 2 minutes. I'm actually in the closing, inshallah. Third case, the treatment life-saving effect wasn't most likely in a habitual way with the likewise cases. This is what I explained before, so I will not repeat it. While it isn't clearly most likely in the specific case for a special reason. So let me just explain this last sentence. Sometimes the statistics say that CPR is not successful usually, but you have the chance to give CPR in the same moment, like in an operating room. In this case, no, the possibility of having success will rise. So you have to give special considerations in some cases, but the general rule, if it's not giving the life-saving effect in a most likely way, in habitual way, then you don't have to give it. Case 4, withholding next dose when the life-saving effect of an uncontinuous treatment became C2 or C3. So this is a concept that I need to discuss with you in a very brief way. Usually, in medical literature, they say withholding for not starting treatment. But what I think the Islamic rulings go along with is considering withholding, not giving the next dose. So in some cases, like in renal kidney dialysis, you can stop the next dose if the patient is classified as a C2 or C3. And C2, C3, we just gone through it. I will not repeat, okay? So you can keep watching the patient, and you can apply the rules even after you start treatment. It will not consider a withdrawing because withdrawing has a special rule that is more stricted. Case 5, in most cases, it's allowed to withhold life-sustaining treatments when the patient refuses it. An exception is when the treatment life-saving effect is absolutely certain. It's not only certain, it's absolutely certain. Like artificial hydration and feeding, tube feeding or something like this. In this case, no, he cannot refuse the treatment. I can explain why and go to details, but time is not enough. Case 6, and I think it's the last, if the chance that the treatment would cause death was bigger or equivalent to the chance that it will save life, then it could be withheld. Case 7, when another patient presents simultaneously, then he have a better survival chance or has a higher mortality risk, then you can refrain from the first patient. Finally, and alhamdulillah, I reached the final slide. I think I reached it. Do not withdraw continuous life-sustaining treatments. And this is a limited description. I think it almost only applies to the ventilators, because it's the only thing that will be really continuous. Here, when you stop, you will give a harmful effect that will cause death. And this is shown by statistics, and that there is a difference between withholding and withdrawal. So when it comes to ventilator, don't stop it and cause death. This is a general rule. Okay, there is some kind of exception if we are about 50% or less success of survival, but I cannot go into details again. So I recommend that this proposed criteria be edited with the help or with the collective effort with physicians. I also hope to see this criteria taking from theory to practice with something like a prospective study of its effects.